if you're wondering why we have so many people in studio with us right now, we are giving over the remainder of the show today to what I hope will be a frank and extensive discussion about hysterectomies. It's prompted largely by a new book and podcast series called Never Waste a Good Hysterectomy, both extremely informative and also very, very funny and very real in their conversation. They are the work of political analyst Melanie Verwoerd, who's been a regular guest on this show over the years. And Melanie, thanks for bringing this story back to us today. I think this could well be the most important conversation we've had in all these years. So lovely to have you with us again. With us also are members of Melanie's own medical team, Dr. Kate Chambers and Dr. Erika Drewes with us in studio. And a little bit later, we'll introduce you to psychologist Abraham le Roux, who will join us by phone. But Kate and Erika, thank you as well for joining us. Lovely to have you here.
Thank you for having us. Thanks for having us.
Melanie, I mean, just to set the scene, we're going to be speaking about various medical aspects of the journey that you had having a hysterectomy and recovering from it. But obviously, it's a much broader conversation than just your journey because it'll be different for every person. Melanie, I guess we have to start at the very beginning of the story. Won't you briefly explain to us how you came to have a hysterectomy?
Yeah, I mean, it came as a big shock. I have to say that. I went for my normal annual gynecological checkup. It was in the middle of COVID. Was chatting away with the gynecologist. It wasn't Dr. Chambers at that stage, but had a chat with the gynecologist, and she suddenly went very quiet while she was doing an ultrasound and said, "Oh, what's this now?" And it was like the air in the room changed, you know. And she asked if I had pain. I thought it's a good thing if you don't. Apparently not. Okay. And then I said, "What are you seeing?" And she said, "I'm seeing a growth on one of your ovaries." And she said, "I need you to go and do a couple of blood tests." And I said, "Why? What are you looking for?" And she said, "Cancer." And that's when everything changed. And after a lot of tests, 2 weeks later, they did a radical hysterectomy because they discovered a ovarian growth, which was the size of the long side of a credit card in diameter. So very big.
Which had been quietly making itself very comfortable without you even recognizing that anything was happening.
Totally. And that is one of the things I have now learned is that gynecological cancers are usually very silent. Our organs are very polite. They make space for any growth.
Well brought up young ladies.
Because they assume that it most probably is pregnancy. So they just, because I couldn't understand how come I didn't have pain, how can something that big grow, like it's the size of a grapefruit it was. So why didn't I know it was there? And it was explained to me that that's the danger of gynecological cancers, that they are often so silent and so quiet. And by the time you discover them, it can be a big crisis. In my case, I was very thankful that it turned out to be one of the rare, something like 3% of the type of growth I had that wasn't cancer. So I was very thankful. But by that stage, I had the hysterectomy, the radical hysterectomy. Yeah.
It's fascinating to me that your body can just make space for something like that without you even realizing it was there. I mean, before this, had you ever even contemplated the thought that one day you might have to have a hysterectomy? Had you known ananybody who had?
So my mom had one, and because my mom had one, I was adamant that I will never have one. I mean, I really did not want one because I can very clearly remember the difficulty my mom had in her recovery process. And I was just adamant that I will never have one, you know, and that it wouldn't be necessary. And I felt so well, and I was relatively young still. I mean, I am still relatively young. Yeah. But, you know, now I know that something like 1 out of 4, you know, so 25% of women will have a hysterectomy by the age of 55. So it's a very, very common thing that happens around the world. And what bugged me is that it was so very few people speak about it, and women go through this very silently, you know.
Not anymore, because of course you decided, well, I'm not going to be silent. I'm going to write about it. And in writing the book, you realized people were responding so much to what you were writing about and talking about that there was a need for these conversations to carry on. So you then launched the podcast, which deals with more of the medical matters. And we're going to touch on some of those now. I mean, what was it purely the realization that those conversations weren't happening anywhere that prompted you to be so frank in writing about it and to start the series?
Yeah, I mean, I then discovered, you know, as I sort of was recovering, that people would whisper to me that they had had one as well, but it was always a whisper. Yeah. And then I was very frustrated that, you know, that it was a long recovery process, much longer than I'd anticipated. It was a real shock on my body and on my psyche, and I felt there wasn't enough support and very little knowledge around it. And so what I then did is I went and looked on the internet and so on, found all these huge Facebook communities which people were part of, but the problem was they were asking each other, none of them were medical people. They were not health practitioners, and that's dangerous, so it's like, I'm bleeding out. Should I go to hospital? And then they would be, and then it's not doctors responding, and I would really worry about that. So I decided the podcast is very different from the book. The book is my personal story, but the podcast is a series of 12 episodes of people like Dr. Drewes and Dr. Chambers, Kate and Erika, that I interviewed on the various aspects of hysterectomy. So that's very much a medical and health side of things. There's one episode for the partners as well, to basically say, get your act in order, don't let your wife do the washing up after the hysterectomy. But the vast majority of it is more on the medical, the psychological, emotional side, and things like when can you have sex again, and things like that.
Dr. Kate Chambers is a gynecologist and obstetrician based at Mediclinic Cape Town. Thank you so much for being with us.
Pleasure.
Kate, Melani's mentioned a stat there that I'm sure shocked many people, as it did me, that 1 in 4 women is likely to have a hysterectomy by 55.
Yeah, I think it's important to realize that hysterectomy is done for many reasons, not just cancer. Cancer is one of the main concerns and the main reason for having a hysterectomy, but a lot of women have hysterectomies for non-cancerous or benign reasons as well. Things like fibroids, or patients who have abnormal bleeding, who are not responding to medical management, have severe pain and can't cope with the medical management that's not working, and they actually need to be able to live their lives and have a decent quality of life. And so the indications for hysterectomies vary quite a lot.
Okay. Now, Melanie mentioned the word a radical hysterectomy, the term. That is what she had, which is the most extreme form of the surgery, which is my understanding. But it's only one, not everybody will have that. Do you want to just explain the different kinds that could be done?
So a radical hysterectomy is the most extreme, and it is done for cancer. Essentially, if you start off at the beginning, a hysterectomy is just removing the uterus. So the uterus is the muscular organ that houses a pregnancy and from where you bleed with your monthly cycle. And if we do a plain hysterectomy, we just remove the uterus. And it can be a total hysterectomy where you remove the uterus and the cervix. So the cervix is the muscular canal that connects the vagina to the uterus. And then if you do just the uterus without the cervix, it's called a subtotal hysterectomy. And then you add in things and procedures such as removing the ovaries, removing the tubes. You add in your terminology. So you would have a hysterectomy with a salpingectomy, which is removing the tubes, or an oophorectomy where you remove the ovaries as well. And the indications for removing tubes, ovaries, cervixes all depends on why you're having the hysterectomy, what's the indication for the procedure, and who your surgeon is as well as how old you are, whether you're premenopausal, postmenopausal. Ideally we don't want to take out ovaries in a premenopausal woman causing menopause. Postmenopause, it's an easier decision because you're kind of protecting them from future cancer anyway. So those are your kind of major differences in hysterectomies. A radical hysterectomy, as Melanie had, is where you remove pretty much everything out of the pelvis. So you take the uterus, the cervix, the ovaries, the tubes, and you take all the ligaments that hold the uterus in place in the abdomen, as well as a little portion of the vagina, just to make sure that you get every part of the cancerous tissue out.
Well, in Melanie's case, not cancerous tissue.
Yes.
Now, one of the things about her story that I find so difficult to wrap my head around, and I know she did too, having read her book, is the fact that this is indicated even if you're not 100% sure that it is cancer. If a man, my understanding is, and correct me if I'm wrong please, but if a man has prostate cancer or suspected prostate cancer, there's a blood test we can do to confirm that and know whether surgery is needed. Why is that not available for women as a matter of interest?
So it's not available because there's no specific test for ovarian cancer, unfortunately, which is one of the trickiest parts of being a gynecologist, is that, as Melanie has said, you go for your one gynae visit and everything's normal, and then suddenly you have a mass and you have no symptoms and, you're suspecting cancer. Cancers, unfortunately, are silent in the ovaries, and we don't have a good screening test for it. We don't have a particular blood test which is specific for the ovary. We have what we call tumor markers, which are blood tests that give us an indication that something might be more serious than others, but once again, not specific. Like with the prostate, you have a specific prostate tumor marker that you can pick up. So there are other methods that you can do to try and minimize the amount of surgery that you do, but those are intraoperative managements, where if you've got a suspicion of ovarian cancer or endometrial cancer, you can do some pathology tests in surgery. So if you take the uterus out, you have a pathologist there who can then look at slides, look at the tissue and say, okay, this is more extensive than we thought, let's take more out. Right. You can also do lymph node dissection, which is obviously the little lymph nodes that sit in our pelvis, which help with infection and everything in your pelvis. If one of those little lymph nodes, if you test it and it has cancer in it, then you know, okay, it's spread a little bit further, let's do some more surgery.
Right.
So, I can't speak for Melanie's gynae, but they obviously had their reasons for doing a full radical hysterectomy, but there are stepwise processes that you can to try and minimize as much surgery as possible.
Our listener Shamala's messaged in to say, I'm preparing to have a hysterectomy, so finding this talk so interesting. I'm really keen to hear about the recovery and pain management afterwards. So that's one of the big questions. And I mean, it's one of the things in Melanie's book that really shocked me. And I have to say, I felt like scolding you reading it, Melanie, because you were really struggling with the fact that it was taking you so long to recover physically. And you write about how you felt a lot of shame that you weren't getting better more quickly, that you weren't being the perfect patient. I felt outraged for you reading that. Is that a common response, Kate? Do you think a lot of women go through that?
I do, and I think that's women's personalities, is that we think we should be up and about going straight away. But there's so much to the recovery besides just the physical that we have to, take into account. First of all, before you have your surgery, the reason why you're having your surgery, you might have been ill before, you might have now suddenly got this diagnosis of cancer. That's a lot of stress that you still have to deal with emotionally, even with the physical aspects after the surgery. And I think people don't realize how big a surgery it is. And, you're removing an organ, depending on how many you remove, but it takes time for your body to recover from the anesthetic drugs, the pain medication, the inflammation, the psychological aspects, and the emotional aspects. So there's a lot more than just the physical recovery.
You should be allowing yourself weeks, though. I mean, this
Definitely.
is not something where the go-get-em superwoman is going to be back at the office and back on her feet doing school lifts a week later, right?
No, definitely. I mean, the type of hysterectomy, there's different types that you can do. Some have a quicker recovery than others. Obviously, with a radical hysterectomy where you're having an open procedure, so you're having to make an incision into the abdomen, your recovery is a lot longer because you've got more layers of the abdomen that need to heal, and you can look up to 6 to 8 weeks just to be able to get back to a physical normality. And that doesn't mean, okay, now after 6 weeks you can go run a marathon. It's then, okay, start going to the gym very slowly, see a physiotherapist, see how you feel. But if you have a vaginal hysterectomy or a laparoscopic hysterectomy where your recovery is technically shorter, it doesn't mean that by 4 weeks you're going to be up and about. It all depends on your pain management, your recovery, and how you as a woman and as your body recovers by itself.
And as you've correctly referenced, it's about more than physical recovery. We do have a psychologist standing by who'll chat to us in a few minutes about that aspect, and then we'll bring in Dr. Drewes as well to talk about the hormonal aspects of what happens after hysterectomy. But pain relief is what Shamala was asking about as well. What sort of pain relief is available post-operatively? So
post-operatively, there's the pain medication that you get in hospital, and then the pain medication that you get when you are sent home. So generally for a hysterectomy, you're in hospital for about 3 days, and your pain is managed by your surgeon as well as your anaesthetist. So during your surgery, you get pain medication, you get opioids and morphine and those sorts of things to help you while you're in surgery. Post-surgery in the ward, because you are well monitored, we can give you the good stuff. So you get the intramuscular injections with pethidine and morphine. You get IV analgesia, and we use a combination of painkillers as well as anti-inflammatories. So we use the synergistic effect of both of them together, and we make sure that you get pain management throughout the day and throughout the night. They're very there are quite a few different ways of giving pain medication, and it kind of depends on your anaesthetist and your surgeon. And what they will do is they'll sit with you and they'll say, okay, what have you reacted to before? What has worked well for you? Let's work out a plan that is specific to you. Unfortunately, when you go home, you can't go home with the IV medication.
Send the good stuff
send
home
the
with
good
you.
stuff
Yeah.
home. But by the time you go home, we generally have weaned you off the IV stuff so that we know off your IV medication you are coping and you're not in too much pain. And then we send you home the same thing with your anti-inflammatories and your pain medication, as well as other things to help with the side effects of all of those sorts of things.
Yeah.
We generally don't want to give you pain medication for too long because we don't want to induce any addictions or dependencies on pain medication. But if you're at home and you're still not coping and your pain medication has run out, there's no reason why you can't phone your surgeon and say, I'm not coping.
managing.
Yeah, just give me something else.
Okay, Sharmila, remember that, please, and don't be
Yes.
afraid to ask if you're in that position. Okay, so you've answered the question about what to do if the pain meds aren't working sufficiently. I mean, you've said again several times now, give yourself time. Don't expect to be rushing back to normal life.
Exactly.
Kate, Melanie's also mentioned the role of partners here. Is any kind of briefing given to the partner or the child or the caregiver who's going to be looking after you after this operation to warn them what to expect?
I must say, no, not really. And I think that's probably a mishap on our behalf as a gynecologist. But often you find women come to their gynecology appointments without their husbands.
Yeah.
And so you don't have that opportunity to chat about what the recovery is going to be with them. And I think with women, as we've said, we are get up, go, let's, get going with the washing. And I've got a 2-year-old home, I need to look after her and do that sort of stuff. And we don't ask enough of our partners. And it is really important because you need to be able to give them that freedom to lie in bed if you're feeling unwell. But I must say, it is something that I should look into a little bit more and perhaps actually advise that patients come in with their husbands before their surgery and you can chat to them a little bit more and give them a little bit more advice.
I want to bring in a psychologist at this point and say a big thank you to Abraham le Roux, who's with us by phone from Knysna this afternoon. Abraham, thank you so much for joining in the show. Welcome.
Hi, thank you, Pippa, for having me.
I know your episode in Melanie's podcast is a very, very gentle and supportive one that is all about saying to women, give yourself the space to heal. And Abraham, that's not just about physical healing. It's also about what you're going through emotionally. And it was a big part of what Melanie wrote about in her book. Tell us a little bit about the kind of emotional response that you expect to see post major surgery. I'm guessing major surgery of any kind will come with that kind of reaction.
Yes, definitely. I think that the main thing, if you can capture it in one word, it is about kindness, and it's a kind of being kind to yourself. And I think that especially women in our culture is so busy looking after other people's needs that they never stop and ask what would be a kind response to my body, to my emotional being, and in that way kind of respond. To take it then further also is to remember that we are going through a grief process. So a woman that has a hysterectomy or is going for one is already starting to grieve about a loss.
That's an interesting perspective, Abram, that I'm sure a lot of women are going, what do you mean grieving? They have removed an organ that was potentially problematic within my body and saved me potentially from something that might have led to my death. What is it that you are grieving? Would you like to elaborate?
Yeah, definitely. I think that most people always grieve about if they lose a part of their body. But I think this is a very significant part of any woman's body. And I think something that kind of a lot of women kind of center her sense of femininity, motherhood, all of those kind of very dear concepts for women actually is around her internal organs. And so when we are suddenly confronted about the loss, then obviously that starts coming into play. But also remember, for example, with Melanie, there was this dread. Is this serious? Is this cancer? Can I die from this? So immediately your own mortality is also on the line.
So, Abram, I mean, those are really important things you've mentioned. And as you said, so much of what society tells us is valuable about us as female is linked to our ability to have children and the presence of a uterus within our bodies, that when that's taken away, it's a lot to come to terms with, even if you didn't subscribe to that sort of social vision of womanhood. What tips would you share with audience members listening today about helping yourself to face that and to ask those questions of yourself and really sort of confront the way you are feeling about what has been taken from you?
Yeah, so I think that like if we stay with the concept of grief, then that would help to actually look at for pointers to help a woman through this process. The first thing, and I think the most dangerous part, is the denial that is passed. And a lot of time they don't realize what the impact is going to be emotionally and physically. So they don't communicate that with their support structures, especially maybe their partners, their husbands, the people that would need to help them afterwards, also dealing with it emotionally. So firstly is just to actually come to terms with it and then to communicate. I was listening to the gynecologist saying that Dr. Chambers, where she said like the husband doesn't come in. It's so important that the husband is present so that he can be aware, or the partner be aware of what she's going to go through, so that he or she can be in a supportive kind of role for the. And then secondly, after that, kind of like if you go moving away from the denial, there's the negotiation phase, and also to know that, oh, can I go for the second opinion? Is this really necessary? There's so many options. To also get all the help you need, kind of talk to the people that really knows and can be supportive in that kind of space. Thirdly, there is their rage, like how could this happen to me? Kind of, this is not fair. Maybe I'm still too young. Maybe I still want to have more children, or how can they take my femininity away or kind of impact on my body in this way? So why is this happening to me and not to anybody else or somebody that I know? So all of that rage also needs to be taken into account and not kind of just pushed away, because I've seen so many women that just kind of push rage down because that is seemingly not the right thing to do. And it causes all sorts of other kind of psychological and even physiological problems. And then kind of feeling sad, the depression that comes, kind of like dealing with the loss. And it's only at the fifth stage that you're starting to come with terms with that. And we need to know that this is going to happen to us and that we're going to need people to help us through that. People close to us, and even in some cases, we're going to need to maybe contact a psychologist in order to help us through a process like this.
I'm so glad you said that, Abram, because my final question to you was going to be around when to seek professional help. I mean, we've heard Kate say, allow yourself the time to heal physically. Don't underestimate what's involved. Inform your partner about what you're going through and speak up if the pain meds aren't working. But there are a lot of women who wouldn't think to speak up when their emotional handling of their response to the operation isn't proving to be easy. At what point would you advise somebody to seek professional help?
Well, clearly when we realize, like, as I said, like the fourth kind of stage is a depressive stage where a natural kind of feelings of feeling down, feeling despondent, feeling why am I not coping yet, all of the things that Melanie also spoke about. But when it prolongs, when you realize, well, this is not me, and it seems like my body is recovering, but emotionally, I'm actually still in quite a bad space, and I'm tearful, I feel I withdraw, I don't have the energy that I should have. I think that's the time that you can speak to your GP or a clinical psychologist to say, like, I need help to reflect on what's happening. And then sometimes therapy is needed, and sometimes even a medical intervention from a medication point of view.
Abraham le Roux, thank you so much for joining us this afternoon from Knysna, a psychologist there speaking to the very important aspect of the emotional recovery. Melanie, if I could just briefly bring you in, and then we must move on to talk hormones. I mean, you write in your book about how what you were dealing with post-operatively really unlocked a whole lot of previous trauma and emotional baggage that you were carrying with you. I mean, with a bit of perspective further down the line, do you think the process of working through the operation and your recovery from it helped with all of that?
Definitely, and I think often a crisis forces you to look at deeper issues in yourself. And I think the issues that I look at and that I looked at and what I write about in the book are issues that women who go through menopause as well deal with often. And a lot of those things are as the hormonal shifts happen in our bodies, whether it's through hysterectomies or through just normal menopause. I think that is when the veil gets lifted around a lot of things that we've suppressed and that we suddenly have to look at.
That's a very neat segue into our next guest, Dr. Erika Drewes, who the one part of the hysterectomy recovery and post-operative impact that we haven't spoken about yet is what's going on with hormones. And Erika is an integrative specialist family physician who's based in Newlands. It's great to have you with us.
Thanks for having me.
I mean, as we've now heard mentioned several times, if you remove the ovaries, obviously that's going to have a major impact on the hormones that your body produces or no longer produces at all. But is there any kind of hormonal impact if the ovaries are left behind, as a matter of interest?
Typically, no. Typically, we would say that's one of the reasons why we would always try and retain the ovaries for a patient. We would like to preserve natural hormone production for them as long as possible. And that's what gynecologists will never just take out the ovaries without very good reason.
Okay. In some cases, though, there is very good reason. And let's talk about what happens next. So you have removed the ovaries, you have removed the kitchen that produces the hormones. What is the impact on the body, Erika?
Well, it depends on the age of the patient. So if the hysterectomy happened before she went into menopause, then it will be quite a dramatic drop in all hormones. And there's been a number of studies looking at it, and is actually it's very severe. Surgical menopause is much, much more severe than gradually going naturally into menopause. So that can be quite radical for a woman, and she can become symptomatic. You probably want to know what kind of symptoms next. So estrogen, there's different kinds of hormones. The three that we can easily replace are estrogen, progesterone, and testosterone. And they all have their own kinds of symptoms related to them. But estrogen is by far probably the most prominent one. So I'll start with that. So that would be your juicy hormone. Estrogen is what lubricates everything in the body. So it's the juiciness in your joints that lubricate them. Without estrogen, your joints become creaky. You start becoming a bit arthralgic. You start thinking you've got your mom's rheumatoid arthritis. Your eyes can become dry. You can struggle with teary eyes. You can have dry skin. Wrinkles can start appearing. You can struggle with a dry vagina. A painful intercourse is usually a sign of that. And then, of course, the hot flushes and the night sweats, which is what most people know about. And then with it comes profound mood disorders, just feeling like you're not yourself, maybe being extremely tearful. And then the menopause brain, you can't remember where you left the car keys. You walk into a room and you can't remember what you came to do there, and those sorts of things. And then the hormone that actually runs nicely next to estrogen, which is called progesterone, it's a balancing hormone to estrogen. So in the body, if estrogen makes something grow, then progesterone comes and modulates it so that it actually stops growing. So they run like two little horses pulling a cart together. And it's actually really important that when you replace hormones for a person, that you actually do both for many reasons. But in this case, I would be very interested in looking at how progesterone supports the brain. Progesterone is really important for calming the brain. The irritability, that need to kill your husband with the kitchen knife will go away when you take your progesterone. You will become a bit more like I said, calm, more together when you have more progesterone. Progesterone also helps to grow bone like estrogen does. Also good for the heart, very good for the brain. There are even studies on neuroplasticity after brain injury where you can see how progesterone actually helps recover brain cells. So it's so much more than just the way that it's often used and seen as sort of helpful in the terms of the uterus.
Yeah.
So I really like using natural progesterone. It's my favorite hormone. And then there's estrogen, testosterone, which is it's also muscle health, it's libido, and there's definitely a very sort of a strong focus also in the guidelines when you've done a hysterectomy in a relatively young person that if there is loss of libido and so on, you have to really look at replacing testosterone as well.
Okay. Now, I just want to mention there is an entire episode in Melanie's podcast that deals with libido issues and all the related things you've touched on, so I'm not going to spend too much time on that today. But you mentioned, Erika, it's far more dramatic for somebody who was premenopausal before having the hysterectomy. What about someone who's already been through menopause? They can still expect, should they still expect some kind of escalation in symptoms after a hysterectomy?
Well, it's interesting. I always try and find papers on these things. I have read that it is seen. It has been described that technically it shouldn't be possible because we're not supposed to have any hormones from the ovary anymore if a woman is postmenopausal. So if you now go and remove non-producing organs, then why would there be a drop?
Yeah.
But that has been described. And I do think just looking at it from an integrative perspective, stress on the body and the stress hormones has got something to do with it. So you actually have other avenues to make estrogen in the body apart from the ovaries. So fatty tissue, for example, can aromatize and create estrogen for you.
Finally, something it's good for.
Not always a good thing. Not a good thing in men. And if you go through a stressful experience, like, for example, a major abdominal surgery, as in the case of hysterectomy, that definitely puts stress on what we call the hypothalamic pituitary adrenal pathway, which is basically this axis of master hormone controllers in the brain that basically cascades down and controls what happens in the adrenal glands. And they kind of triangular shaped little glands that sit on top of our kidneys. And they produce all our fight and flight hormones, our adrenaline, and then also cortisol. And I often see that when women, even postmenopausal women with ovaries but who are on hormones, they will come to me for example, after a stressful event like that, and they will say, oh, my menopause symptoms are back. I'm flushing again, I'm sweating again, and that's because of the stress that they've been through. So often then just actually working on getting out of fight or flight, doing your breathing exercises, getting enough sleep, and maybe taking some herbal tonics can restore you back to balance, and your hormones will actually be calmed down again. So I think that there's probably an interplay with other hormones in the postmenopausal person who gets a hysterectomy.
Okay, so in terms of managing afterwards, obviously you're going to have a conversation about what's going on with your hormones, what sort of hormone replacement options are available and possible for you, Erika. You've also mentioned several lifestyle factors there. Is there anything else that you want to just mention in terms of getting past and beyond the operation?
Well, I think that there's these days in the modern world, we actually have got so much. Women actually have got way more options in Cape Town than they realize, and also in the rest of the country, but I'm just talking about what I know in this area. But a lot of women find healing in what I call bodywork therapies. Yes, you can do physiotherapy, which is sort of the mainstay, and there's a lot of specialists who focus just on pelvic floor rehabilitation and things like that. I think that's really important because we worry about, for example, bladder function and things like that down the line. But just integrating yourself again, just finding a new normal for yourself. There are things what I would call in the energy world. So things like craniosacral osteopathy, things like kinesiology, things like trauma release exercise are wonderful ways of releasing trauma, because remember, the trauma is not just in the soul or in the spirit. The trauma is actually at the body level. And people who've done trauma research actually tells you that though the higher mind, the cognitive mind, has now been processing, and it's written books and it's moved on from the trauma, the body is still in the trauma. And that's why you actually have to do the actual body work to try and release some of that memory in the tissue.
From your own cells. Wow.
Yes.
I mean, it's a fascinating conversation that we could probably dedicate 2 hours or more to on its own. But thank you again. You've done a very good job of giving us a sort of an overview, Dr. Erika Drewes. Thank you for that. I want to just share a couple of the WhatsApps that have come in from listeners listening today who've been through this and are sharing their stories. And how radically different some of these stories are is fascinating to me. Anonymous saying, I had a full hysterectomy at age 38 after they found a large fibroid. I'd battled to fall pregnant and never had children. Physically, I made it. Mentally, it took me a long time to accept it. And now I'm battling hormones at age 47. Someone telling me they had a voluntary hysterectomy at the age of 44. No grieving. For them, there was celebration of the newfound freedom that gave them, and they see it as the best thing that they ever did. Thank you for that. A great chat, says Anonymous. I always remember a nurse saying to my mom to try and cheer her up, they've taken the nursery but left behind the playground. I think that's a lovely way of looking at it. Thank you for that. This message astounds and distresses me, and I'm very interested to hear our guests respond. Just for those coming in late to the conversation, the guests are Melanie Verwoerd, who has written about her own experience and spoken about it in her podcast series, Never Waste a Good Hysterectomy. We also have with us gynecologist Dr. Kate Chambers and hormone specialist, integrative specialist family physician Dr. Erika Drewes. Listen to this. Somebody writes, I am 77 years old. I had a hysterectomy 50 years ago. Is there a way of finding out just what was removed? I was 27 and didn't ask questions. I still get hot flushes. I had a vaginal op. Now, it astonishes me that somebody doesn't know the extent of the operation. Melanie, you're not surprised. You said to me in the break that this has actually come up several times.
Kate, I know, is a fantastic gynecologist, but others, I mean, I hear this all the time from women that they were just shoved out in 2 minutes and said, you're fine now, go live your life, and that's not quite how women operate.
And not how they deserve to be treated.
No, not after such a big surgery. For me, the one thing, Pippa, that I think that most importantly for me is that I've now come to understand that hysterectomies can be life-saving, they can be life-improving. But whatever they are, they're a big deal. And women need to understand it's a big deal, and they need to demand the support and the care for such a big deal. It's a massive surgery, one of the biggest they still routinely do as medical professionals. And so you need to demand the support and the help from the medical people around you, your health team, and then also from your family and your partner. It's really important, because otherwise you're going to really suffer.
Which is why I think it's so important that you've been so frank in sharing your story, particularly in the book and in the podcast series. The podcast is being downloaded literally all over the world. I mean, that tells you, and in it by the thousands, that tells you how much hunger there is for this kind of information.
The podcast has been absolutely flying, and it's all over the world. Places like Costa Rica, Antigua, Jamaica, everywhere in the world, women are downloading it and responding to me by email and saying thank you, because women feel very lonely in this journey. So yes, and the book is, people are responding to that because it is, like you say, a very frank story. It's my story, and I think sometimes women can relate to other women's stories. And so, I mean, I hope more and more women will also listen to the podcast, even if they've had hysterectomies decades ago, 50 years ago. I think it's still very useful, and women seem to find it very interesting. And even women who are not dealing with hysterectomies, the hormone episode that Erika was on is super interesting for anybody who's going through menopause and so on. There's an anesthetic episode. Anybody who's ever had to get an operation or general anesthetic is super interesting.
So please go and look for them. We are going to tweet the link. You can find the podcast series on it's iono.fm is the best place to go.
Or it is on all the others, Apple, Spotify, everywhere.
Okay, so that is called Never Waste a Good Hysterectomy. That is the same title as the book. And Melanie, you very generously offered a discount on the book for CapeTalk listeners
yes,
today.
If people want to go and look on my website, Melanie Verwoerd, melanieverwoerd.co.za, and they just go to, it's very obvious where the book is. And the book is, I've given it a big markdown for CapeTalk listeners. So
you can get a copy today for 250 Rand if you go and order on melanieverwoerd.co.za. I'm going to say to you what I said to you the night of the book launch. Thank you for writing it. Thank you for starting this conversation, Melanie. They are many, many women who have never had anyone to talk to about this and have never known the kinds of questions they should be asking. So thank you for just bringing them to the table. And to our guests today, Dr. Kate Chambers and Dr. Erika Drewes, thank you for the role that you've played in supporting so many women. I wish I had time to read you some of the messages coming through from your own patients to say how wonderful you've been in helping them. But thank you for joining us today and really enlightening our audience as well.
Lunch with Pippa Hudson
on CapeTalk.